I am really pleased today that we've got a couple folks from Wake Forest Health with us, and I do want, if you will, as a participant, I want to give you a little bit of a Zoom orientation. At this point in the pandemic, sure, everybody should be a Zoom expert, right? But I don't like to presume. So notice that you have all come into the meeting muted. And if you could stay muted, that would be excellent. I'm going to let Keith and Dr. Bischoff say a few words here in just a minute, but then we are going to open it up for questions. And it would be great if for this meeting in particular, you could use the raise hand function. And I'll tell you where to find that. If you see the participants icon on your control panel, you should be down at the bottom if you're on a computer, or if you tap the screen and get the control panel, you should see it looks like little people. It says participants. If you click on that, the participants box will pop up and you'll see everybody's name. And at the bottom of that box, you should see a little blue hand. It says raise hand. And if you just click that, you can practice it now if you like. Click the raise hand function. And in your corner, you'll see in your picture or over there beside you that there's a little raise hand, right? So if you have a question, if you just want to click your raise hand button, that would be awesome. And then I will ask to unmute you, and then you can just ask your question verbally. You can also feel free to type questions in the chat. Hannah and I are here and we'll be monitoring the chat, so we can also take questions through the chat box. So, and keep in mind, you can also save the chat. If you see the down at the bottom where it says to everyone, and there's a place to type your message, over to the right there are three little dots in a box, and if you click those three little dots, you'll see there's an option to save your chat. And that would give you all the links or anything that interesting that got shared, then it'll save it to a little text file on your hard drive so that you can get to it later. You may also be interested in knowing how to toggle in between the gallery view and the speaker view. In your top right corner, if you're on a computer, you should see, might say speaker view, might say gallery view. And if you click it, if it says speaker view, you'll get a big Ruth. Whoever's speaking becomes the person in the big window. If you click it when it says gallery view, then you get the Brady Bunch kind of look, which is what I tend to prefer for this meeting since a lot of different people participate. Also know that you can hide yourself. I know we're all getting into a lot of Zoom fatigue, and part of that I think is having to police ourselves. So if you roll your mouse over your picture on the gallery view, for example, click the three little dots in the corner of your screen there, you'll see it says hide self view. And then you don't have to look at yourself. Just keep in mind everyone else can still see you. But I like to tell people about that because it is, I think, somewhat helpful in terms of the Zoom fatigue. If you start to have issues with bandwidth, you may want to click stop video. Then your voice will be clearer when you're speaking if you decide to speak. So those are just kind of my standard Zoom etiquette suggestions for you. I'm really pleased today that we have the Reverend Keith Stirewalt with us. Keith is the Program Director for Faith Health Clinical Medicine at Wake Health. And then we also have Dr. Werner Ernst Bischoff with us. And he is the Medical Director of Infection Prevention and a Health System Epidemiologist, studying the spread, the control, the overall impact of infectious disease, and overseeing the infection prevention and control activity of the entire Wake Forest Baptist Health System. So he is quite a popular person right now, and we are really appreciative of his time to be with us. Dr. Bischoff, these are just a bunch of random Moravians from all over the place and a few friends. Keith, I'm going to turn it over to you first and let you and Dr. Bishop maybe give us some updates, some things you think it might be useful for us to know, and then we'll entertain questions. And if we don't have any audience questions, I've got a few I'm sure that we can get us going. So Keith, I'll let you take it away.
Thank you. The first thing is I want to express thanks to both to Ruth and the group for inviting me today, but also to Dr. Bischoff. As I told him yesterday, unfortunately, I'm having to ask favors of people who I really can't pay back. And I owe him two favors at least by now. And so it was very gracious of him because he is a very popular person. I imagine he wishes he weren't quite so popular right now. And maybe we all wish for a day when the infectious disease specialty can just be one of the other specialties or one of the many medical specialties. The main thing that I wanted to mention, because I want to make sure that we give adequate time to Dr. Bischoff, is that Faith Health, the work that we're doing, we're really observing, as you all know from the news, that folks who have been disadvantaged economically, socially, certainly medically, over decades, we are seeing the horrible side effects, so as you will, of poor health provided to many in our congregations, in many in our cities and counties. And so what Faith Health is focusing on right now is actually working primarily with the North Carolina Baptist Association, with others as well, to try to get testing to disadvantaged populations, to get it out to people who don't have transportation, but also to make sure that masks are available. I am lucky. I can work from home most of the time. I can, and the nice thing is I can wear a t-shirt and shorts and exist, but many of the people that we work with don't have that luxury. They have to go into work. They have to be exposed to many people, and again, they haven't had the best health care, to be frank with you, because of access, and we are just heartbroken. And so we're trying to do what we can to help with what's going on right now with COVID. But the truth is, we have decades worth of health inequities to make up for, and so that's our focus.
So yeah, I think yeah, thank you very much, and for inviting me, and thanks for the nice introduction. And I can only kind of mirror what Keith just told you regarding where we are right now and what we are looking at, and that a huge component is actually not something that just kind of came along, but that has been unfortunately. The foundation has been laid decades ago, starting with taking away kind of our social safety net, public health, etc., and cutting. And unfortunately, the ones that really suffer with COVID-19 are the ones that really need our help right now, and that are not so privileged to have the access that we probably all have to healthcare and good living circumstances, nice houses, etc., and so on. So I want to give you a very quick overview where we are. As of this morning, 3:35 a.m. I wasn't up there, but that is when Johns Hopkins updates their website. So over 5 million confirmed cases worldwide. The death rate is over 654,000 worldwide, and in the United States we are now at close to 4.3 million confirmed cases, 148,056 deaths. In North Carolina, and I don't know where you're all coming from, but just for North Carolina, we have now over 114,000 cases with 1,790 deaths as of yesterday noon. Looking at the trends, etc., in the United States, you probably see that everywhere on the news that it's going up and up and up. So it's definitely not leveling out. And I think in North Carolina, we are still in a very kind of good situation compared to other states, especially kind of Texas and Florida, etc. So it doesn't look really very promising for the next few weeks or months where we are and where we will be. My prediction is that's always a prediction that everybody can take or leave. And if you leave it, I'm not actually upset with that. That we probably will see a further increase in numbers, and also other states actually kind of impacted by that. And so COVID-19 is not leaving us very soon. So I think we have to prepare for that and have to make the best out of what we have right now, and yeah, implement some simple methods to disrupt the spread. So that's kind of my intro into that. And yeah, I don't know, kind of now questions. Now that is kind of organized.
Well, I'm sure there are folks who have a few questions.
Otherwise, we're gonna oops.
No, I was going to say, I've got my list, I know.
Yes. I can juggle. I just don't have anything to juggle here with.
Well, you know, it's interesting. I just saw an exchange this morning. Of course, Facebook, you know, right? So many MDs on Facebook, right, that have their medical degrees hanging out on Facebook. But there was I saw an exchange about sort of that whole conversation about the flu. And I just wondered if you could address the whole idea that this is just a flu.
Yeah. So I think just looking at the data and at the numbers that we have right now, so I just told you kind of where we are in the United States with the fatality numbers. So we have now close to 150,000 confirmed deaths related to COVID-19. During a normal influenza season, you have around 26 to, if it is a really bad season, 80,000 deaths. So that gives you kind of perspective what COVID-19 does. So it's definitely worse than your normal seasonal influenza. I also would like to warn people that we are now outside of our usual influenza season. So our hospital is now starting to prepare actually for influenza. And I guarantee you, influenza doesn't look at COVID-19 and says, oh, hey, you're already here, I'm not coming around. Yeah, not this time. We will have influenza and we will have COVID-19. And we will have also other respiratory viruses that we usually observe during that season. And the season really starts in September, October of each year, and it goes kind of to March, May of the following year. So that's also why we are kind of looking into that, and we try to promote influenza vaccine. Please get it. That's a really good way to protect and spread the word and let other people have also the influenza vaccine, because you don't want to have influenza and COVID-19 on top of it. So that is where we are kind of afraid what happens next when we have the other respiratory viruses coming
in. Riddick, I'm gonna unmute you. You ask your question.
Yeah, it was actually more of sort of a follow-up comment on what he just pointed out related to when you compare flu and COVID. And, you know, as you say, the numbers point out that this is not just like the flu. In addition, those bad flu years, those happen when the economy's up and running. And we took huge steps earlier on to shut down COVID virus, the disease. And yet we still wound up with massively inflated numbers compared to the flu. So I think when you add those two numbers together or take both of those things into consideration, it really does argue against the idea that this is just a bad flu.
Yep.
I've also seen a lot of conflicting data around sort of, is this mostly something we get from the air or from droplets, or is this something that if I touch the grocery, right, I'm gonna get it? Can you address that a little bit in terms of which is worse or how to? Yeah.
So I think the primary route of transmission is really over the air, and looking at the epidemiology of it, I think large droplets that contain a lot of virus, these are the ones that we really are afraid of. Yeah. Now, if you don't have a mask on and you sneeze, etc., or cough, these large droplets, of course, get onto surfaces that are around you. Then if another person comes by, touches the surface, and then touches the face, the nose, etc., then there is a potential of transmission. we really do not know yet what kind of percentage is kind of air to contact to other surface stuff. But I think what we have in place is pretty much covering all our bases. What we have learned from influenza, from other respiratory viruses, that they are all predominantly transferred by air, but they can also be transmitted via a surface that is contaminated with the virus. Mm-hmm. So I'm definitely advocating that the hand washing, hand hygiene is a huge part in that. The biggest one is your mask, the community mask, the cloth mask that you have on, but really do not let up on hand hygiene and also frequently cleaning your surfaces that are around you. The one thing is that a bunch of people are always point that out. It's kind of the cell phone, yeah. That's the one item that you touch all the time, and guess where you have it? You have it very close to your mouth. You put it on your head to hear, etc. So very good idea to do that on a daily basis, at least once, to clean your cell phone too, or if you feel, you know what, you just touch something, doorknobs, etc., and then you touch your cell phone, that you just wipe it down too.
Thank you. Peggy, I was going to let you go ahead and talk if you want to unmute yourself.
Thanks, Ruth, for hosting this, and Dr. Bischoff and Keith. My concern is sort of a mental, emotional health concern. As we hear updates about the COVID, we also hear updates of the rising concern about emotional and mental health. During treatment, while people are in treatment and then following up, is there mental or emotional health resources available? And how might we address that if there are not as well? Because I know that even for families that are involved with their family members with COVID.
Yeah. So, and I can talk a little bit here about what we are doing for our employees, and I think that I have to refer to KEYS and CareNet system, etc., and what they are doing there for patients that really has a need. First and foremost, this is really tough dealing with COVID-19, especially if a family member is impacted by it. And we have here kind of these restrictions in place with putting patients on isolation, and that is really straining. And I completely realize that this is definitely something that we have to be very aware of, and balancing kind of, okay, what we try to do with isolating patients to contain the virus, and what harm we are doing to patients when we actually put them in isolation and have them there. And also for all the other family members that cannot visit easily, and these are seriously sick patients. So that also kind of is all kind of coming into the equation. So we have loosened up our visitation policy to account for that, to say, you know what, look, you can come in here, you can see your loved one. We still have restrictions in place, but we try to be kind of conscientious and making a point that we allow that. For our employees in a healthcare setting, you probably understand there's a lot of stress now on our folks here, and so we have a very good kind of assistance program in place that we also point out, and I have my team too, that I pretty much tell them, you know what, look, if you feel overwhelmed, then seek out the assistance programs that we have in place here. They are fantastic, and they can help you getting through it. It's not only, it's the emotional element that can be overwhelming, taking care 24/7 of patients. Then coming home, even if you have taken care of these patients and you're pretty much in the same situation, taking care of your family, etc., and trying to have this threat hanging over you your entire time. So that gets on folks, and I realize that. So these are some of the measures that we are taking to address that. And I think maybe Keith can comment on the CareNet part and the support that we can give your patients and family members too.
Certainly. One of the first things I want to point out is that Wake Forest Baptist Health has always maintained that visitation by clergy is an important part of a patient's healing. So even though we have restricted visitation in very noticeable ways. When you come in our hospital now, you have your temperature taken. I think that's still going on. Is that still going on, Dr. Bischoff? And there's also a limitation to hours. These restrictions, other than making sure that they're well and not febrile, don't occur for clergy, because again, we realize we can't talk about mind, body, spirit and then just ignore the spirit part when it suits us best. So I'm very proud that Wake Forest has made those accommodations. So we're focusing on that. When it comes to care of the patient, some of the isolation that's occurred, we have tried to get past with iPads. There are a number of iPads so that we can actually facilitate FaceTime and other kinds of Zoom meetings with family, because of the loneliness is there. Our staff, as Dr. Bischoff was saying, are going through incredible stress. Sometimes having to be with patients who can't have visitors because of distance, or because people are sick at home, or just because they're so sick they can't, like I said, they can't have someone actually come physically into the room. We're doing everything that we can as our staff try to ramp up their spiritual care, their emotional care of our patients, to care for them as well. And so in addition to all the wellness, the standard kind of wellness things that Wake Forest does for all of their clinical and administrative staff, we also have financial resources. In this day, there are an incredible number of people who don't have employment. And so if your spouse is without a job, even if they are collecting unemployment, we're having employees very close to losing where they live, to losing their car, to just on and on and on. So we actually have our own internal fund where we assist our employees with financial emergencies. How can we expect you to take care of patients when you're worried about your car being repossessed in a couple weeks and you may not have the ability to get here, or when you're worried about being put out of your apartment whenever that restriction ends, about the foreclosures and people being evicted? So we're doing everything we can to deal with the financial aspect. CareNet has retooled itself, so to speak. And CareNet, for those of you who do not know, it's our pastoral counseling arm. It's actually one of the larger pastoral counseling groups in the United States. Obviously, like a lot of medical practices, and other clinical practices, they're doing a lot of telehealth as much as possible. So we have those aspects available. And it's not just for people who are directly affected by COVID, but for those who have ongoing mental health issues, where they need to continue to see their counselor, where they need to continue to see their psychiatrist. We have tried to reach out through the digital format, through a digital format, to bridge that. The problem is the same thing we were talking about early on, which was that divide of the haves and have-nots, certainly occurs when it comes to the digital divide. And it's not just the urban poor. In some areas of North Carolina, as you're aware, you have trouble getting a cell phone signal. And so telehealth for people in some areas of rural North Carolina is a fantasy. And so we are trying to reach out in many ways. Is that helpful?
Absolutely. Thank you.
Thank you, Keith. I'm going to go to Erin next. Erin has a question from the hinterlands of Canada.
I actually have two questions, and the context for these two is we have many different user groups in our church building normally, including other congregation and different dance groups as well. And I have not seen how long is the virus viable outside of a host, and how are there ways that we can sort of limit and mitigate the exposure in the air between our different groups? So like, does higher airflow help with that, or does that just help spread the virus around? So yeah, those are the two.
Yeah. So and these are questions, actually, these are great, and I'm working here with our university and the school there, and these are coming up all the time, kind of different groups using kind of the same venues, and how can that be safely done? I think the one part that I want to start with, the first one is, while you have your activity, there are some activities that are prone to and have been described causing outbreaks. And you're probably aware of the choir, So singing is wonderful, and it's fantastic, but having quite a few people singing very loudly in the same room, that's pretty much a recipe that you can spread COVID-19 very easily in these. So I would also kind of put in activities where you have a lot of motion and etc. in there, so dancing, etc. So there are kind of these activities where I'm feeling uncomfortable putting them inside a room. Everything that you can do outside is better than inside. So if the temperature allows, and right now I don't want to go outside here, it's very hot and very humid, but maybe over there it's a little bit better. But if you can do some of that stuff outside, it's always kind of the better venue to do that. But if you want to do something inside, you really have to limit the folks that are in the room while they're doing that. So, and there are different recommendations. The social distancing is usually looking at 6 feet apart. If there are activities where you have people moving around a lot or even working out, I would say probably 10 to 12 feet is something that you could try, but it's not a guarantee that this will actually contain the virus. The problem with inside indoor venues is that you have air circulation. Usually they are all kind of climate controlled, etc. You have your HVAC system that churns over the air over and over. And that, of course, is a nice distribution of virus too. Respiratory viruses love these environments. So at least kind of from what I have recommended for school settings with these activities, to try not to do them if it is not absolutely necessary. And if you have to do them outside. If that is not possible, then very much limit the number of folks that are indoors, and stretch them out as far as you can in your indoor venues. So that's kind of for I think for your groups there. For the survival of the virus in the air and on surfaces, so I can say 3-4 hours definitely in the air that they can be detected, and studies have been done to look at the COVID-19 virus. On surfaces, up to a few days, especially on metal, etc. So kind of stainless steel. So again, frequent cleaning of these high-touch areas, doorknobs, etc., counters, where folks are kind of attending to touch these areas. It's really crucial to get rid of them. These are laboratory studies. So part of it is they create an environment that is pretty much ideal for the virus to survive. So these are conservative measures. Probably the virus is not as long-lived in the environment. However, I think that's as good as we can get right now with looking at survival of the virus. But the CDC uses kind of the more than 15 minutes together with a person closer than 6 feet in distance. And that is for us a definition of a real exposure. So you can kind of play around with that. If you have practice that goes over 15 minutes, 6 feet is probably not good enough to be kind of separated. But I have done a lot of site visits to look at venues, trust me, to tell people, okay, look, that is what you can do and that is what you shouldn't do. So, but all these activities that that you can defer, I think that would be the best situation, especially if you have vulnerable people coming in there. So the elderly or folks with pre-existing conditions, let's say cancer patients, etc. you should discourage folks going to these get-togethers, etc., because it's just too high a risk, and you don't want to have a publication where you kind of see then, okay, that was church this, and there have been some outbreaks that actually were related to some of these practices that I would feel terrible being kind of in that situation and losing kind of members of my church because of an outbreak.
Thank you. Dr. Bishop, could you, there are several clergy on this call, and I know that we get asked about regathering in person in our churches. Do you have, I mean, I know you don't have a magic ball, a crystal ball to be able to tell the future, but any kind of time frame on when it might be safe to gather in person in like a worship setting?
So, and I think we are, and that's the same for me. I'm kind of looking at, is there an endpoint? Yeah, and working on that for a very long time, for quite a few months now. It's kind of, okay, when is that all ending? And my colleague suggested that we stick with July 4th, 2021. It's pretty much kind of saying, you know what, there are a lot of vaccine candidates out there that are promising. Looking at production ramp up, looking at the steps that these vaccines have to go through to be safe and effective. I think it's realistic to probably have beginning of next year some candidates that are very promising. And then moving into production and then vaccinating folks. That will take some time and real effort. But hopefully if that works out, that by the mid of next year, we would be out of the woods, and it would be for me to say, you know what, look, we are going back to some kind of normal pre-COVID status, which is always kind of this thing that I realize this is not really a great satisfying response to people that say, look, we have already months and months that I didn't see my friends, my church members, etc. And I know this is really, really hard. There are some recommendations by the CDC that are easily available that you can look at, how you can maybe safely get at least a few folks back in. But again, look at your local situation too. If you're in a county where the numbers are getting really high up there, or you have already very high numbers, again, the safe thing to do is not to actually then have church gatherings coming together. If you are in a county that has very, very low numbers, and you can see that on your state health department website, they have very nice information there and maps that you can easily see kind of where you are falling. And you know the folks are coming all from your surrounding area and your community. So there may be a better chance that you actually are not in real big trouble if you have these meetings, starting them off. But it really goes county by county and congregation by congregation. If you have cases already in your congregation that have been tested COVID-19 positive, that would be also for me more a sign to delay a little bit.
That makes sense. Some folks may have some follow-ups, but I know Vince has a question he wants to ask, and then Cindy has a question for you.
Thank you, Dr. Bishop. I know that you mentioned choral singing as being a high-risk activity for churches, and being indoors at all is a high risk. I'm wondering about the risk of other things that we do in church, whether it's inside or outside. For example, public speaking. Is 6 feet enough if you're a liturgy reader or a pastor, or passing an offering plate? Is that something we should avoid? Those kinds of things. Of the things that we do in church, we also play a lot of brass instruments.
Yep.
Is 6 feet enough if you are a tuba player and you want to space yourself away from the trombone player?
Yeah,
Does that
so-
include the spit valve? I've been showered by spit valves. Does that include that, sir?
Yeah, actually, there are recommendations what you do with the fluid in your instrument. So, and you should actually not put it just on the floor. So, but this is very complex, and I always tell people look at kind of your 6 feet distance as a recommendation by the CDC. If you have a cloth mask or a community mask on, or whatever mask you want to put on, and the folks surrounding you also have masks on, that is pretty much the best protection that you can have in a close environment where you want to see people. Yeah. So that probably is not great if you have public speaking. Yeah. And the cloth mask or surgical mask is quite annoying to have there. Yeah. So the louder you speak, the more you actually kind of expel the virus. Yeah. So if you have microphones to keep your voice pretty much low, yeah, that also reduces the risk that folks that are sitting in front of you, that are in the direction of your airflow that you are producing, that is also a safe way. I usually recommend for these activities with microphone without a mask, but the folks are masked that are sitting in front of you, probably 10 feet would be a nice distance to keep. Yeah. Offering things, etc., and having closer contact. Both parties a mask on, no problem if it's not over 15 minutes. Yeah. And again, the mask really have to cover the mouth and the nose, and not just kind of the classical under the nose. I don't know what that means, but it's just kind of, you can then do these activities too. It is a quick kind of interaction that you have with the persons there. And oh yeah, the instruments, yeah, a lot of discussions there also for Big Forest University and their bands and music practices and something like that. And pretty much we ended up, or I ended up to recommend, you know what, if you can, go outside, yeah, 10 feet apart and play your instruments, which usually is not really kind of a great band experience that people want to have, but that gives you an opportunity to actually kind of practice and do some stuff. There are some other folks that have tried things like a mask that actually folks put on, and then they have a little slit where they have for oboe or whatever, can have the mouthpiece coming in there. I think you are still blowing out the air through the instrument. Yeah. And I'm kind of a little bit hesitant to recommend that as a great solution. I would still keep the distance, etc.
Mm-hmm. That makes sense. Cindy, if you want to go ahead and ask your question.
Thank you, Ruth. I think you touched on this before, but my question is looking forward. Once the vaccine is approved, how, Dr. Bischoff, do you envision this unfolding for the public, for congregations, for meeting groups that have limited their gatherings during this time?
Yeah. So I think it would be, and I predict that this will be kind of a nationwide campaign. So you're going into the hotspots first, so the areas where you see a lot of COVID-19 activity, and try to vaccinate as many folks as you can. Yeah. So there's public health is coming in there. So your health department of the county is probably coordinating that, and I bet there probably will also be outreach to communities and congregations like yours, saying, you know what, can you help us? Can you coordinate that and give us the facilities to do that? Yeah. So I think that's kind of the rollout that I envision, that we are going from the hotspots and to the less impacted areas that have to deal with COVID-19. My biggest concern is that we probably have to deal with also anti-vaxxers, so folks that do not want to have the vaccine. And that will be definitely kind of an uphill battle that we are not only having for COVID-19, but also for the measles, mumps, rubella vaccine and other vaccines, influenza, etc. So any support that we can get from leaders like you would be fantastic to say, no, what's the safe ones that went through all the testing and it's effective and it's the best way to do that all together, so we can actually kind of fight this COVID-19 virus.
That makes sense. Andrew Heil has a question in our chat box. It's essentially asking about gatherings with children, school, etc. The information reported suggests transmission is low and maybe even different for kids. And he wonders if we've gathered sufficient research and data to substantiate a lower transmission rate among small children.
Yeah, I think they are, and then that's correct. I think looking at the makeup of patients that we are seeing that have to that require medical care, so the younger ones are a lot less likely to be really hit hard by COVID-19. However, there are cases where we have actually kind of in younger populations where we see actually patients that have been affected by COVID-19. And so it is not completely out that they are absolutely not impacted by it. And everybody who had children know when they are starting kindergarten, it's pretty much from then on, every second week they get another virus. Yeah, so, and they bring it home. And I think that's the biggest thing that I say. The young ones may not be impacted as badly by COVID-19. However, they spreading it probably, they are very nice resources or sources for COVID-19 to spread them in the community. So they are running around. It's very hard to tell a 5-year-old to wash their hands or not wipe their face or whatever, or put a mask on. And so I think even if there's a low transmission rate within the age group, I predict that what we have seen for other respiratory viruses, that these strive in kindergarten, first to second to third to fourth to fifth grade, etc. And they will actually probably be then causing hotspots in the adult population and then going to grandparents, etc. So I know the school opening discussions are really hot right now, and I'm also kind of part of that too. And it's very, very hard how to exactly kind of plan that in a safe way. At least the schools that my kids are going to, they pretty much have kind of a rotating schedule. So they reduce the number of students that are actually present at school. Even have it optional for the high school students. It's a smaller school, I think they can do that. And again, I think we have to find a way to somehow get them back to a normal schedule, because I do not feel that this is sustainable and actually good for the kids if they are for such a long time out of school. But now at summer vacation, of course, that's fantastic for everyone. But I know that my kids are kind of, they had a hard time adjusting to that. And I can see that also with my friends, etc. This is a very hard thing to do. And I think it's not a good service for the kids, but we have to make sure that they are safe, and we are doing it in a very controlled way.
Right. Now Dave has a question. I did want to follow up on your question though around, oh, no, I'm going to let Dave talk.
Yeah, I have just a couple of questions. One is can you tell us a little bit of information about what the curves look like for cases with different vaccination rates? And the second question is that there seems to be a lot of variability in projections. I'm just curious, there's, different models. Which, is there one model that is better than others, or is there one that's being used?
Yeah.
And how does the model accommodate different reporting structures in the different states?
Mm-hmm. No, I think these are fantastic questions, and I usually give a lecture about modeling of infectious diseases, and the one quote that I always tell my students is, all models are wrong, but some are useful. Yeah. So is there one model that stands out that we say, oh yeah, hey, that was pretty much, no, there's not. It's, as you said, there are so many factors that you have to kind of look into and try to put into your model. And models are always simplifications of what is really going on. So it is very hard to tell you, okay, look, this model probably is correct and we will see X, Y, and Z. I have seen several models that have shown kind of different waves coming through. Which I think the extension of the first wave that I feel we are still in there hasn't been really accounted for in these models. So they are pretty much out of the window. And then as we go along, our models will get better and better predicting what's next because we have more and more experience with it. The best model is when it's all over and you just have a graph and how it was. So that's your real life model, yeah. So, what was the second question? I'm sorry, I kind of said.
Oh, the vaccination rates. Is there any, using, yeah. I mean, there's got to be a point where, if the number is low for people getting vaccinated, it doesn't really shift the curve that much.
Yeah, and there are also a lot of different takes on that right now. I think the term herd immunity comes to mind. So if you have a percentage of people in the community that are immune to it, let it be over a vaccine or let it be that they actually went through the infection and developed the antibodies that they need against COVID-19 virus. And again, there are folks that say that 20 to 30% of the population, if they have been exposed, we should be all protected. We are reaching herd immunity level. Other folks talking about 70, 80% in their models. When I went to school, it was more in the 90% range for herd immunity to reach that. Unfortunately, I really don't have an answer for that. I wish it would be 20 to 30%. A very low number, I would say. And I think it probably is a little bit too optimistic, what I can see. But that's kind of where we are right now. So there are no real kind of great answers right now where we are. Models are only telling us half of it. And then next week, it's a little bit different and short.
Dr. Bischoff, Ruth's dog is still barking, so I'm going to ask this follow-up question that she has, and I'll try not to bark while I do it. Her follow-up question about school was, what tips do you have for teachers? It's very difficult to socially distance for 6 hours a day and have kids keep their masks on. How can teachers, or how do they keep themselves and those around them safe?
Yeah. So, if you can, and again, kind of a face mask is really very, very good to put that on. And also the kids, even if some struggle, it has to be a rule that it's not tolerated if a person takes off the mask and says, you know what, it's not for me or whatever, then the person is probably not really mature enough to follow the lessons anyway. So I really kind of recommend having masks on and giving these lectures. The other thing is for a teacher is, again, follow exactly the advice that the CDC is giving and WHO is giving. So frequent hand hygiene, yeah, wash your hands, use these disinfectants, even if it is annoying, but it's a very simple, very effective way. Make a conscious decision not to touch your face, yeah, when you're around these folks, yeah. And you can get close to a person if the person has a mask on and you have a mask on too. Yeah, it doesn't mean that you have to stay away always 6 feet. Yeah, especially when taking care of smaller kids, etc. You have to help them, etc. So the 15-minute rule, yeah, that's a good one. Yeah, just kind of lean over, tell them what to do, but both of you have a mask on. There shouldn't be any issue with that. And then again, frequent cleaning of surfaces. Yeah, kids are usually not really great with their personal hygiene, not well developed. So wiping the surfaces down on a very frequent basis, even if it's after each class, might be really helpful to prevent spread of the virus. So these are kind of the first and foremost interventions that you can do to protect yourself. Some folks talk about putting on a face shield too, in addition of the face mask. The face shield does not replace the face mask. The face shield doesn't keep out really kind of the very small particles, but it can protect you from the large particles a little bit more. So it's adding a little bit more, but it's what we encourage people to put on here, but we are not really demanding them to do it. With the mask, it's more mandatory in our healthcare setting, and it's the same I would say apply in school settings.
Great. Okay. Thank you so much. Keith, you said you have a question, and I don't know if anyone else has. If they want to put their hand up, we're at about 6 minutes to 2. I want to be a good steward of your time, but Keith, go ahead.
So my question, Dr. Bischoff, is when this happens again, because I think if I live long enough, I'll unfortunately live long enough to see something, hopefully not on this order again, but something like this happen again. I'd love to see the churches as leaders in public health, and not as followers. Not that all of us were, but you know, what do you have any specific suggestions about how we as a nation could do a better job next time? I'm not asking you to get political. We have enough of that. So you're not. I'm not running for office, and nor to my knowledge are you. But how can we, both as a nation, and I think as churches, as centers of faith and centers of health, do a better job of getting out in front of this next time?
Yeah. So I think it's maybe a little bit what we talked about before, when we have a vaccine, etc. Being a partner to your health departments, your kind of social network that promotes good information, that also admits when we really don't have all the answers right now, but also helps people not to fall into the trap of Facebook and other kind of sites that usually are not productive at all. So I think there's kind of that component in spreading actually good information that is helpful for people, that doesn't make them panic, but makes them also take it seriously. And I think that is where I see that you all are kind of really, you can be really kind of the army that we need to actually kind of spread that. And really, on one hand, make sure that people take it seriously. On the other hand, calming down unreasonable fears that some folks will develop when they are confronted with that. And you probably have all seen that in your groups. It is a little bit kind of how the human mind works. And some folks are okay. They are dealing with that in a very rational way. And some folks are pretty much, very much lost in that. So trying to catch them, I think that's really important. Moving forward, it would be very nice if we would have more functioning public health system in place. And so looking at the support that we have for our health departments, they were not prepared at all for that. And so again, it takes time to build that up. And it can also not be that right now we are pumping a few millions or billions into the systems, and 5 years later we cut them all again down to whatever. So it has to be a process that keeps on, and that we have a high level of preparedness carrying on into the future. For myself, so predicting the future, probably that's not the last one that I will have with the pandemic or being involved in response to that. So the coronavirus is in SARS-CoV-2. The COVID virus is also coronavirus, as you know. So every 10 years we have one new one popping up. So I can calculate to my retirement, so I have one more. Yes. And we have other candidates that also are standing there. And the more we are getting actually into into nature, into natural environments, the more we are exposed to these viruses that may have been around for decades, centuries, etc. But now humans are encroaching on all these areas, and we get these viruses then kind of imported into our circumstances, and they can, as we see with COVID-19 virus, they can really do a lot of harm. So being conscientious about that and saying, okay, let's prepare for that. Let's keep on going, because that won't be the last time that we will have to deal with something like that. I hope the next time around it will be a bit easier. Some of you probably will remember the H1N1 pandemic. So that was an influenza virus. And we were kind of still in the early beginnings of developing vaccines. So we have made great progress actually in accelerating the development of vaccines. However, the influenza virus that we had then in there, it was very quickly done to get a vaccine, because we are used to developing influenza vaccines. We are not used to developing vaccines for coronaviruses. Yeah. So, but I think with our technical know-how that we actually pushed into place after the H1N1 pandemic, I think we were already a little bit better prepared than before the H1N1 pandemic. So again, it's a balance. We are moving forward. I think we are getting better in responding to that. But the biggest thing that is here lacking that I can see is really the public health component, spreading the good news about, okay, what can you do, what you shouldn't do, and then kind of moving forward in a safe way.
Wonderful. Thank you. Thanks so much. I'm cognizant of our time. If there are no other burning questions, perhaps we can have you gentlemen back another time, maybe a few more months, and it'll be a more hopeful meeting. I wanted to end the Moravians have a daily text. It's a daily devotional book. I don't know if you're familiar with it, Dr. Bischoff. Keith needs to give you a copy, but one of the texts for today comes from Corinthians. I'm going to end with that. It says, "We are afflicted in every way, but not crushed, perplexed, but not driven to despair." So I think that is a good word of hope for us to end on today. I thank you very much for joining us. I thank all of you who've joined us, our attendees, and we'll move into August, where hopefully we'll hear from the PEC. We hope to have some educators on talking about digital children's ministry, and we're also going to sort of talk about what we're learning as a church during the pandemic. So I hope you'll be able to join us for some of those. Look to our e-news for the specific dates. So thank you all, and I will let you go.